Great. Good morning, everybody, and thank you for joining. We have a great speaker this morning, Sandeep Basvaraya, who is joining us from the UK. And Sandeep has really become an expert in coronary interventions and CTOs, but also in the field of drug-coated balloons, where I don't think I go to a meeting and I don't see you giving a lecture, Sandeep. So I'm very proud. For the little part I've taken in that. So me and Sandeep know each other for a long time. He was one of my fellows a number of years ago, and so it's amazing to see how well he's excelled and become really world renowned in this field.
Thank you so much, Azim, for the very kind introduction. Actually, I think you understated it. A few influence or little influence. I think you had a massive influence on my career, and I'm not kind of saying just because you're here and your team is there. I think I looked up to you, the whole time I spent with Colombo, and you supported us very well, and we did so much together. But I learned that. But the thing is that I carried on. I remember you telling me once, I don't like going to a meeting if I'm not presenting or if I'm not in the, I don't like going and sitting in the meeting, and which is so true actually. Now I'm doing this regularly. I had to go to a meeting when I'm presenting. So thanks to you, and thanks for all your kind words. So essentially, I have interest in complex intervention, CTOs, and drug-coated balloon, as Azim said. So can I share my screen?
Please go ahead.
Perfect. So I'll share this screen. Can you see the screen?
Yes, we can.
Okay, so I'll just do the swap this.
Yeah, good. You got to do that. Duplicate. Perfect. Oops, and we lost you. Share again.
Yeah, I'll share again. Can you see me now? Can you
Uh,
see the presentation?
no.
So maybe we'll share again. Um,
Okay, it's coming now. Okay, we see you.
what about now?
Perfect. Perfect.
Perfect. So, okay, so I know DCBs kind of alien in the US, although I'm very pleased to hear that it's now been approved for ISR in clinical use after the
So,
trial
Sandeep,
completion.
there'll also be some general cardiology fellows on who don't know our lingo and abbreviations. So maybe as you go through, just explain what DCB means too,
Oh,
okay?
yes. Sure, sure. So drug-coated balloons are basically a kind of a technology where we deliver the anti-proliferative drug like paclitaxel or sirolimus over a balloon rather than a stent. So in a stent, of course, you're coating this drug on a metal platform with a polymer, and the drug elutes into the artery over a period of 3 to 6 months. Um, of course, after the drug's gone, all you're left with a metal polymer, metal and maybe a polymer. Whereas with the drug-coated balloon, you have a uniform coating of the same drug on a balloon. The rationale is you inflate the balloon for sort of 60 to 90 seconds, and we aim that, or we expect that the drug to diffuse into the artery, and we take the balloon out. So all you'll be left is a drug which kind of goes anywhere between 1 month to 3 months. After that, there'll be nothing left behind. So this is the rationale for using a drug-coated balloon. But I will, of course, come to the more details. So DCB stands for drug-coated balloon. It used to be called drug-eluting balloon in the past, but I think the terminology has been changed because essentially it doesn't elute, because like stent, it elutes over time from a specific platform. Whereas here it's coated and it doesn't elute, it just goes into the artery and that's it. So of course, DCBs have been around since 2003. I was speaking to Bruno Scheller, who's one of the big names in DCBs, one of the pioneers. He said he did his first DCB in human arteries, in coronary arteries in 2003. So it's been around for almost 2 decades. But they were initially kind of designed for in-stent restenosis, but now there is more expanding indication, which is I'll go through that. So, what is the rationale for using a DCB? For that, I think it's good to understand a brief history of angioplasty, especially if you have younger fellows. I'm sure you all know this father of intervention, Andreas Gertzig, who performed the first angioplasty in September 1977. And of course, the artery treated was a proximal LAD. So this is the before intervention, this is after. This was a plain balloon angioplasty. And look at this. This was in 1977. And in 1987, you see a bit of positive remodeling. So 10 years later, the artery is still open. And even in 2000, maybe some mild recoil or some new disease, but still the artery is open. So almost 23 years later, the artery was still open. So that's how the balloon angioplasty was born. So this was in 1977. So essentially, you take a balloon, you inflate it, you expect the narrowing to get bigger, and improve the blood flow. So it was successful in almost 60 to 70% of cases. The complication of balloon angioplasty were dissections, obviously, which were flow limiting, which means the abrupt closure of the vessel because of the dissection, the blood entering the false lumen, and then it closes of the true lumen. And of course, thrombosis is basically you form a clot within the artery. So these were the two main limitations for balloon angioplasty. And of course, there was another complication called recoil, which was probably more subacute or more chronic, where these were like immediate. You could lose the patient in a matter of minutes to hours. So how was this tackled? So this was tackled with a metal stent. So essentially gives a scaffolding so that there is no recoil. And if there is any dissection, it's sealed. So there's no thrombus formation. So this was the kind of solution for complication of balloon angioplasty. So the bare metal stents were invented in 1990s. So which kind of gave a metal scaffold. But the problem was because it was a metal, it attracted all the restenotic tissue, and hence it was causing restenosis over time. Although you were able to address the acute issues, but long term it was causing restenosis. And this is just a slide showing the bare metal stent. This is at 30 days, and at 90 days, you could see development of hyperplastic tissue. So how was this tackled? This was tackled by coating these metal stents with drugs like limus or paclitaxel, which inhibits this intimal hyperplasia. So this, you could see the difference here. This is a bare metal stent at 30 days and the drug-eluting stent at 30 days. You can see a very, very mild hyperplasia as compared to what you see in the bare metal stent. And again, at 90 days, you could see the difference in the development of hyperplasia within the drug-eluting stent. So the restenosis rates dropped to less than 10% with drug-eluting stents. So the first generation drug-eluting stents were basically thicker struts. So they had almost 140 to 150 micron thickness of the metal platforms, and they were stainless steel, had a polymer to deliver the drug, which was pro-inflammatory, and there was a luminal coating of the drug, so the drug got delivered straight into the lumen. So the problem obviously was the stent thrombosis, which was first reported in 2006 ESC in Barcelona, which kind of scared all the interventionists. So then there was a constant urge to improve the drug-eluting stents. Of course, then we got into the second and third generation drug-eluting stents, which are basically thinner struts. Now we have stents which are as thin as 60 microns. On an average, it's around 80 microns. The Zion stents are 87 microns. And we have alloy, which is a mixture of metals. So instead of having a stainless steel, they added cobalt, chromium, or platinum chromium. And of course, there are nowadays dural polymer. Sometimes you even have a bioabsorbable polymer. In some stents, there is no polymer. So essentially, these are done to minimize the stent thrombosis and restenosis. And now we have abluminal coating of the drug. So the drug is coated more onto the outer surface of the stent. So it's delivered more into the arterial side than into the lumen, which can trigger thrombosis. So with the second generation and third generation drug-eluting stents, the event rates drop to very low, less than 1% stent thrombosis per year, restenosis less than 5%, but it is not zero. So if you look at some of the trials, the event rates keep going up, so it will never plateau with even the best drug-eluting stents we have. So the present state of angioplasty, so we have all this fancy technology, shockwave, diamond bag, rotational atherectomy, and all these fancy imaging device. But the ultimate goal is to place stents. But maybe in the future, the PCI may be different. So maybe we'll start drinking water in a different way. So these kind of pictures look very nice, maybe 15, 10 years ago, where you had all this full metal jacket, even you don't need any contrast to identify the artery. But not so sure whether we can do that. So if you're treating an RCA like this, which is heavily calcified, I put stents because I put 4 millimeter stent and maybe even 4.55. So 4.5, 5 millimeter stents very rarely causes problem unless you have not deployed the stents properly. Whereas if you're dealing with the vessels like these are like diffusely diseased small vessels, coronary disease. The problem is where you find a healthy zone where to land your stent, where to end. So of course, these are the lesions you will end up making into a full metal jacket. So for example, this artery was treated with full metal jacket. You could see over time, the artery is blocked off. So it's all thrombosed and restenosis. And the problem with these kind of restenosis is very, very difficult to treat. No matter what you do, they keep coming back. This was one of the publications I did with Azim and Antonio Colombo. This was the extended full metal jacket. It's a 5 years data. This was published in CCI 2014. So again, if you look at the data here, this is the MACE curve, which basically shows at 5 years, your MACE rate is 30% or 34%. Again, say with the TVR. So imagine having a MACE rate or a TLR or TVR of over 30% at 5 years, which is not a good sign for patients, especially if you're putting stents in the small vessels and long lesions. And of course, you have patients with diabetic and chronic renal failure and calcification. These factors enhances the outcome in the long term, like restenosis and stent thrombosis. Now we have come to realize maybe stenting by default may not be a good thing, especially in certain patient and lesion subsets. So of course, we thought, what about leaving nothing behind? Stents are just a scaffold. They're only needed for a few weeks, a few months. And once the stents job are done, which is recoil and providing sealing all the dissection, they're not needed. But unfortunately, we cannot take the stents out like the way we can do for these scaffolds in the building site. So of course, we thought of having an absorbable scaffold. In fact, me and Azim had a amazing argument on this, because I remember when this came out, I was very excited. And Azim mentioned, are you happy when a stent dissolves with inflammation? I didn't exactly get what he meant at the time, but now I realize when your stent is disappearing with inflammation, you have a lot of fibrotic tissues, which is probably one of the problem with these absorbable scaffolds. So essentially, these scaffolds don't go away in like 6 months or 1 year. They take up to 4 years. For example, this is one of the early patients treated in the BVS trials. Baseline, you can see these scaffolds. 6 months, you get coating of the neointima. And over time, it goes inside, and at 5 years, it's completely gone. And we have treated a patient like this in our center, diffusely diseased LAD, which we constructed the whole LAD with a full plastic jacket, which is a BVS. And we had a great result. We had demonstrated on OCT, the scaffolds were very nicely embedded in the artery. And even at 25 months, patient was doing great. And again, we did the OCT at 25 months. It was nicely embedded in the artery. And at 5 years, you could see the artery was completely free of scaffold. And we have published this case in a few journals. But unfortunately, this was not the case for all the cases treated in the Absorb trial. I think you may have seen this, that there was almost a threefold increase in the scaffold thrombosis as compared to stent thrombosis when looked at in the randomized trial, Absorb 3 and 4. So we also saw some of these nasty images where the scaffold, when they were getting absorbed, dismantled and fell into the lumen and caused thrombosis. And of course, FDA warned this in 2017, and it was taken out of clinical practice. So we don't use BVS in Europe. I'm sure it's same in US, unless we're part of a clinical trial. So if you go back to complications of angioplasty, as I said, there were dissection, thrombosis, and recoil, but it was successful in almost 60 to 70% of cases. These complications occurred in only 30% of cases, but we applied the stent to those who had success in 60 to 70% of cases. So what are the options? We have drug-coated balloon. So as I mentioned earlier, drug-coated balloons, there are some advantages over stents. So for example, unlike stents, these are homogeneously coated on the balloon, whereas in the stent, it's more of an island distribution. And because there is no metal work left behind, it kind of maintains the original artery anatomy. And I'll show you a nice case. It avoids chronic inflammation because you've got nothing left behind, no polymer or no stents. And hence, you can even reduce the DAPT to as low as 2 weeks in some patients. Whereas with the stents, you have to give for at least 6 months or a year. Some of the DCBs are excellent for deliverability, like we can deliver 40 millimeter magic touch or solution without any problem. Whereas if I want to deliver a 40 millimeter stent, sometimes I have to think about having a guide liner or a buddy wire and other stuff. So leaving nothing behind is exciting. And I show you this case. This is a case of an acute MI presented in our center recently. A young chap, he's only sort of 42. So of course we performed thrombus aspiration and established some flow in the artery. And then we did some NC balloon dilatation, and we had a post-POBA result like this. The problem in this case was there was a lot of thrombus. I was a bit reluctant to put a stent in, and I was not sure what is the actual size of the vessel because it's probably underfilled in the setting of acute MI. And because he was so young, I decided to give GP2B3 inhibitors, which is we use tirofiban, and I used 2 long DCBs. Now we have several DCBs, paclitaxel being the majority of them, and then you have these days sirolimus one. I tend to use more sirolimus. I'm happy to take questions. Why do I do it, especially in acute MI? Because it causes less embolization of the particle and hence less slow flow. So this was the final result. Okay, again, it doesn't look like a stent-like result, but I've established TIMI3 flow. Patient's totally asymptomatic. ECG had resolved, so I took him off the table. Now I brought the patient back for a follow-up angiogram because he had some disease on the other side. And look at the artery now. It's very difficult to identify where there was occlusion, where the disease was. And more importantly, look at the way this artery moves. It kind of folds very freely like a snake. Now, if I had put a stent in, I would have cased this and probably it would have lost that natural vasomotion of the artery. Now, whether that would cause any clinical benefit, we don't know yet. The studies are going. But just to show you that how the DCB works with the maintaining the original artery anatomy. So this is just a post-procedure and a follow-up angiogram, just to kind of give you how positively the remodel the artery is now. So where can we use DCB? What do the literature says? I'm just going to go into the literature a little bit. Won't dwell it for long. As I said, the DCBs were mainly invented to treat in-stent restenosis, and the rationale being we wanted to avoid another layer of metal in a previously failed stent. So that's why the DCBs were put in, so that we can put some drug without second layer of stent. Now, what do we have the evidence-wise? We have plenty of evidence in the literature since 2005 that they can be considered in in-stent restenosis. And in fact, we have an endorsement from the European Society of Guidelines, ESC guidelines, 2014 and 2018, that a class 1 indication where we can use DCB. But the most important aspects of DCB, this is what I learned, of course, from Azim when I was there in Italy. You have to ensure underlying mechanical issues are corrected. There's no point using either a drug-eluting stent or a DCB without understanding why the stent has failed. So that every ISR, you have to have an intravascular imaging. It's a mandatory. And of course, you can use some scoring and cutting balloon prior to DCB, which will come to that. I'll show you this case because this is a case where I learned a lot from. So this is a patient who had an ISR of a circumflex stent. The operator had used 3 millimeter stent and had taken, I think, up to 325. Okay, so with this ISR, obviously I was mandated to do imaging. Now, when I did the imaging, so this, I'll play this, you could see here the stents are significantly undersized for the vessel. The vessel is big, and you could see the stents are floating. Okay, and you could also see some in-stent restenosis inside the stent. Now, what amazed me was, of course, this stent was floating. Okay, but if you look at the proximal reference of the circumflex, you could see it's almost 4.5 to 5 millimeter. If you look at the distal reference, okay, where the stent is there, it's 4.5. So it's a big vessel. So this is clearly undersized stent. So because I did the IVUS, I had the confidence to take a 4.5 millimeter NC balloon and even a 5 millimeter, which I would have never dreamt without an IVUS. And then I corrected the mechanical issue. So of course, this is a pre. You could see the stents are floating, but then here post, they are nicely expanded. and I ensured there was no fracture in the stent. And I corrected the mechanical issue and I used a DCB. This patient was done almost 4 or 5 years ago and hasn't come back. This is before pandemic. And this is a hot from the press. This was done only a few months ago in my unit. So this patient had a severe ISR of intermediate artery, which was treated. So I'll show, this is probably on the picture. You could see there's a severe ISR of intermediate artery stent. Okay, here. So this was treated on 29th of Feb in our unit. Okay. Unfortunately, the operator did not use IVUS. All they did was they took an NC balloon 3 millimeter and they put a long DCB and they stopped and they established the flow was Dimitri anyway. You could see there's significant recoil. This was accepted as a good result. The problem was patient came back 5 days later with end STEMI. And of course, I had a look at, I knew what exactly the problem was. I did an IVUS. Okay, I ballooned it a little bit and I did an IVUS. I'll play this IVUS. You could see here that this is distal. Okay, as you come in here, you see here the stent is small. Okay, and there's a lot of calcium here. There's an echo dropout. Okay, and you come here again, you see here the stent. There's a stent here. There's a big artery. Okay, and moreover, there's again here, there's a lot of calcium in the stents. There's so much calcium here. So the problem was there was a lot of mechanical issue. There's a calcium which was not expanded. Stent was significantly undersized, and there was an area where there was no stent. So there was a gap between the two stents placed before. So of course, now I knew what was the problem. I took an IVL balloon. So this is a 3 millimeter IVL balloon. We took all the 12 pulsations and we expanded further with the NC balloon at high pressures. And we repeated the IVUS. Now, IVUS, I'll show you now. The stent's bigger. You could clearly see the stent looks bigger in some areas. There's still calcium, okay? But certainly the stent looks bigger, but there was a lot of recoil, okay? So here. So what I did was I decided to use a stent here, not a DCB, because there was recoil despite using the IVL and an NC balloon. It was expanding, but it was recoiling. So the thing is to place a stent, and we had a great result with the stent here. And this is the final result, okay? And this patient obviously was done in March, and she has done well. She hasn't come back yet, okay? So this is just a final IVUS to show that the stent is fully expanded nicely. Now, how about de novo lesions? This is not in the European guidelines yet, and I'm sure it's not available in America for even clinical use. Maybe for the research, it's coming on, and hopefully we'll be part of some trial with the ZIM in the coming months. Data now in the European system exists only for small vessels, i.e. less than 3 millimeter. There are 5 randomized control to date. I'm not going to go through all of them in the interest of time. Of course, the first one was done by Azim and Antonio Colombo, called the Bello trial in 2012. Obviously, in this, they compared paclitaxel-coated balloon with a paclitaxel-eluting stent, which we don't use anymore. So obviously, I'm going to discuss about that trial. I'm just going to show you 2 trials, Basket Small 2 and a Piccolato 2 trial. So Basket Small 2 trial, they randomized around 750 patients to either a drug-coated balloon or a drug-coating stent in a small vessels, okay, less than 3 millimeter. Okay, so this was a clinical follow-up endpoint study. So they looked at the MACE at 12 months. So there was no difference between drug-coating stent and drug-coated balloon. Even at 3 years, there was no difference. Now, if you're a DCB enthusiast, you will say, great. But if you're a stent enthusiast, you may say, look, I've not seen any difference. Why should I change my practice? But that's fine. But at least if you're a DCB user, you could reassure yourself, yes, I can use DCB in small vessels. Then you have Piccolato 2, again, from the Italian group, Bernardo Cortes. He's one of, again, a DCB expert. They randomized, it's a small trial, 232 patients to either a DCB or a Zions drug-coating stent. This was more of an angiographic endpoint study. So they looked at the late lumen loss. Generally, the late lumen loss for any of the best drug-coating stent these days are 0.16 to 0.17. That was fine. But for the DCB, it's 0.04. You could see there was a very minimal late lumen loss with the DCB as compared to stent. So it was not only non-inferior, but it was superior over drug-coating stent. But this was not, found to be any different clinically when they looked at the clinical endpoints. But they presented this 3-year data, I think 2 years ago, the TCT, where they said at the 3 years, the MACE was better in the DCB as compared to drug-eluting stent. How about large vessels? If someone wants to treat this with the DCB, I personally wouldn't, okay? And I only use that if someone has a high bleeding risk awaiting an urgent cancer surgery. And people who use probably are like this. You should be careful using a DCB in large vessels. I strongly recommend this because I've seen in meetings people using left main, LAD, proximal LAD with DCB. Maybe you can get away, but if you have litigation system like what you have in US, even in UK, we can be heavily criticized. So, in conclusion, DCB probably should be the first choice in diffuse disease and small vessels, and also the important side branch ostium. So, if you got 001 bifurcation, if you want to treat this with with a stent, you all know it's very difficult to nail the stent right at the ostium, because the moment you put a wire in, the angle changes from 90 degrees to maybe 70 or 80 degrees, and either you'll miss the ostium or you'll come into the main branch, and then you have to convert this into a DK crush or whatever. Whereas with the DCB, you have that liberty of bringing the balloon into the main branch without having to worry because it's just a balloon. And of course, high bleeding risk patients, we use a lot in this sort of population, especially elderly, diabetic, anemic patient. If they're waiting for a cancer surgery or urgent operation, we use DCB. With this, I would like to show you guys, this was a case done in 2014, and I'll show you how we have transformed. This was the time I was appointed as a consultant in Birmingham. I had come out from Columbus unit 2 years earlier, so heavily enthusiastic with angioplasty. So I met up a 58-year-old man with angina. Okay, so he had some stent in the LAD in the proximal segment, but the whole LAD was diffusely diseased. So this was in February 2014. So what I did, I ended up treating the whole LAD with a full metal jacket. So literally you could see the stent from there to there. It was done IVUS guided, properly done. Diabetic man, CKD. Okay, what happens? 2 years later, he presents with angina. Okay, and I could start seeing the trouble. There's a recoil and restenosis here. And of course, you could see the distal AD is kind of blocked off. Okay, and in 2017, what happens? It completely blocked off. So 3 years from the procedure, patient has a restenosis, almost occlusive restenosis. Okay, and in 2023, you could see what has happened in the patient. He has developed ischemic cardiomyopathy. He's got ICD. Okay, he's in big trouble. This chap underwent transplant in the end. But how we have changed. This is now 2021 to 2014. Let's rewind. Let's forward to 2021. How do we treat? So this is a case I treated, a couple of years ago. Heavily calcified LAD, end-stage renal failure, patient on dialysis. Okay, so how did you do? We do upfront rotablation. We NC ballooned it. Okay, we NC ballooned, further balloon dilatation, and then we decided what to do, where to start and where to stop stenting. Okay, full metal jacket, small stent, renal failure patient, diabetic. I'm sure she'll come back in a few years' time with more trouble. So we decided to use hybrid strategy. So what is that? We use drug-coated balloon, mid to distal segment, and drug-eluting stent proximally. So you could see here, we use DCB here, and we used a big drug-eluting stent. Okay. Sorry, it's not playing. Okay, so hopefully this play. Okay. Sorry, I'm not know why it's not playing. Anyway, so essentially we had a good result. Okay, this is the check angiogram. Maybe it's not playing. It's playing. Okay, sorry for this. Okay, maybe you could see here. This is post-procedure. There was a lot of dissection, and follow-up angiogram looks great. I'm sorry, I don't know why it's not playing. This is another case. Okay, diffusely diseased LAD. So if you want to treat this with stent, you all straighten out this artery with caging the vessel, maybe from here to here. We used DCB here, and this is the final result. Okay, you could see there's a dissection here. Now, if I ask people to accept this as a acceptable result in the current era, people will say, no freaking way. Okay, but because of our experience with the DCB, we accepted this. Okay, patient came back for a check angiogram for 6 months. You could see the whole dissection is healed, and there is no metal, and angiographically it remodeled nicely. And you could see the post-procedure, how badly it was dissected and how it looks now. Of course, we won the case. Okay. This is another case where we used a DCB in a very diffuse diseased LAD. Again, all the usual risk factors. This was done in October last year as a part of the live case. We used a DCB and a stent in the proximal segment, and we had a result like this. Again, it doesn't look great because it looks as if there is a lot of dissection, recoil. But the last thing you want to do is put a stent here, 2 mm stent or a 225. So we accepted this, and patient had an angiographic follow-up at 4 months. You could see it may not look great, it may not look bigger, but patient's completely asymptomatic. It has remodeled, all the dissection is healed up, so we are happy. So this was in January 2024, so it's 4-5 months later. Okay, so you could see the post-procedure and the follow-up angiogram. You could see the healing of the dissection. So what we have avoided in this patient is a full metal jacket, which we all know has a long-term implications. Bifurcation, as I said, this is a case we did in our place. So this was a acute MI of a PDA, so occlusion of the PDA flush occlusion. Okay, so we opened this, ballooned it with an NC balloon. So we had a TIMI3 flow, ECG got better, patient became asymptomatic. Now, if I'm using a stent, I'm happy to go and put a stent here because the balloon is expanded. But if I want to use a DCB, this is not an optimal result because you could see there's a recoil here. Okay, now you could see there's a big size mismatch. So if I want to stent, okay, so I have to place a stent from here to here. So what size I would take? Maybe 2.5, but I have to optimize with at least 3.5 or 4 mm here. Okay, so and you have to use an IVUS. So I wanted to avoid the stent. So we used a scoring balloon, and this is a post-scoring balloon. We had a good POBA result. Okay, so obviously we used a DCB here. So the good thing here, the DCBs convert almost into the proximal segment, okay, because we don't have to worry like stent nailing right at the ostium. So you come back into the main artery, and when I inflate, okay, so it's not playing. Essentially, we inflated this, and we had a good result like this. Okay, there was no stent at all, and patient had a check angiogram a few weeks later, and you could see the arteries open. So we avoided another layer of metal. This is a last case. Okay, now this case is interesting because when I show this case to a bifurcation enthusiast, okay, so this is a heavily calcified LAD with two very complex bifurcations. So first diagonal and the second diagonal. So I ask, how do you treat? They all say, okay, maybe we could do a DK crush, and a stent. So essentially, you're putting 3 stents in these branches. Again, this is a patient who's has got diabetes, renal failure, calcification. So what I want to do is I wanted to avoid stenting here. So I ballooned the main segment because I could not wire the artery here because it was so diseased. I could not even turn the wire. So I just ballooned, I wired the main branch, the LAD, and the first diagonal. I could not wire the second diagonal. So I ballooned it. And after ballooning, unfortunately, this is not playing. Sorry, guys. So after ballooning, there was a loss of flow in the diagonal, but patient was completely asymptomatic. And I managed to use a supercross to cross this. And we used a drug-coated balloon in the second diagonal and the first diagonal. And we had a result like this. Now you could see here, there is a dissection in the second diagonal, okay, and potentially in the first diagonal, but they both have TIMI3 flow. Patient had no ECG changes. He was totally asymptomatic. And the main branch was stented with a drug-eluting stent. Okay, so patient came back for a check angiogram a few weeks later. You could see the artery is still open. So the diagonals are open. Patient's completely asymptomatic. Yes, I could have probably put a stent in these diagonals, but it's not needed. You could use DCB, and I've shown in this case the dissection is in fact almost healing in the second diagonal. In the first diagonal, is completely healed up. So maybe you could see the post-procedure dissection, and that is nicely healing. And the first diagonal, it's almost healed. So in conclusion, we are not against stents because stents are needed for most cases. So in my hospital, we use stents in almost 50% of cases, and in another 50% we use DCB because we treat a lot of small vessels, long lesions, and more importantly, we are a big renal center. So DCB should be viewed as a complementary to stents. Stenting should not be the default choice in all lesion subset, especially small vessels, long lesions. DCB certainly have a role in certain lesions and patient subset, which are basically ISR, small vessels de novo lesions, maybe hybrid in this patient, and side branch osteum, especially if you've got a complex bifurcation where you want to avoid 2 layers of metal. We have, I mean, this is obviously more for the Europeans as of now. We have to nurture and look after this technology, because I see in some meetings where they show some really complex cases of proximal LAD treated with a DCB. The operators are extremely experienced, so probably they are doing a great job. But what I don't want is to be emulated in a less experienced operator and bring a bad name to the technology and to themselves. So, which is why I keep saying in the meetings that we have to explain to them that DCB angioplasty is not fairly straightforward angioplasty like we do balloon and stenting. We have to prepare the lesion, be more aggressive in lesion preparation. We have to look after the artery, assess the post-POBA result before we use DCB, and it involves lots of steps. It's a big learning curve. We started DCB in 2014 in my unit when I started my job here, and now we are 50% DCB users. It's taken us almost 10 years to get to this level. So it's important as an experienced operator like us. Of course, Azim does a lot of cases when he was in Italy, and many other operators, that we have to slowly teach this technology to the non-experienced operators. Thank you so much.
Sandeep, that was phenomenal. Great cases as well, and truly shows, your expertise in using drug-coated balloons and how useful they are for patients. Yeah, I'll give you an update of where we are in the US a little before I pass on to our faculty and fellows who have questions. So as you know, we have the first drug-coated balloon agent from Boston Scientific approved after a randomized trial that we just finished with them. And that's only approved for in-stent restenosis. Just to remind us, Sandeep, how much do you pay for a drug-coated balloon and how much do you pay for a drug-eluting stent in the United Kingdom, which is no longer part of Europe? So everything must cost a lot more money.
No, well, no, not necessarily. We pay cheaper than the Europeans actually. So let's give you an example of our drug-eluting stents. We pay anywhere between 180 to 230 pounds for one drug-eluting stent.
Okay. And
Okay,
for the balloon?
Okay, for the balloon, we pay anywhere between 400 to 500 pounds.
Okay.
So it's basically double the price.
Right. So let
So
me tell you about the wonderful health system we have in America. So I just managed to negotiate to get our drug-eluting stent price lower. We have one of the lowest prices, I think, in the country in New York. So I'm getting it now about 450. But most places pay $800 for a drug-eluting stent. Okay. Boston Scientific is about to commercialize their drug-coated balloon, and after the rebate, okay, the invoice price, sorry, is $6,100. After the rebate, it's $5,600. So it's 10 times.
This is yeah. I don't know. I don't think so. This will last longer. They have to bring it down. But you're right. If you have that kind of price, it's very difficult to justify
Very
using.
difficult. Well, for now, we can only use it for restenosis it's like gold. We keep it under lock and key in a safe, and in very strict indications. But when I hear you doing it in 50% of your cases, I'm jealous, because when I left Europe, I was doing it in about 25% of my cases, and I'd be at 50% right now. And I remember using 6 or 7 in one patient at time. So we got a little bit of way to go, but it's now here, and there's going to be lots of clinical studies. There are other clinical studies, as you know, Concept Medical, I'm the PI for. We're starting that clinical study. There's Solution. There are going to be a lot of clinical studies. So we'll have more drug-coated balloons, and having more will cause competition and drive down the prices. But
I'm sure.
let's see. We have some questions from the fellows. Sahul, I saw your hand go up. You got a question?
Yes, hi, good morning. Thank you very much for this talk. We learned a lot, and we're very excited to have our first drug-coated balloon. As you know, it's the paclitaxel coated one, so I wanted to know your opinion about why are they using paclitaxel if we know the paclitaxel coated stents are inferior to everolimus? Do you prefer other agents to be used in drug-coated balloons? And my second question, what's your strategy on patients with one single layer of stent and their first episode of in-stent restenosis? Do you still go with drug-coated balloons, or do you put as a new stent in a patient that has a single layer of stent? Because we know drug-coated balloons are superior to standard balloons, but we still don't know if they are superior to putting another stent. So what would your approach be in this case?
That's a good question. You asked me two important questions. The first one being the paclitaxel. Why? Because one, the depth of the data we have for paclitaxel balloon is enormous. The second, the mechanism of action, how it acts. So the paclitaxel is a extremely lipophilic drug. So it gets into the vessel wall much easier than a sirolimus. And in fact, there's some study published by Alok at the TCT, which he has looked into the details of how it acts in the arterial wall, essentially cause myocardial necrosis of the media of the artery, which is why you get this positive remodeling. Now, especially in small vessels, when the artery is only 2.5 or 225, you want that positive remodeling. And of course, you achieve that better with the paclitaxel than with the sirolimus, at least as of now. So we have got the Transform 1 data, which was published last year, which essentially showed that paclitaxel gives a better remodeling than sirolimus. Whether that will have any clinical impact, we don't know yet because there is no head-to-head clinical comparison. But given the amount of data and with the way the paclitaxel works, I think that should be the first choice. The only time I tend to use more sirolimus is that because it's so deliverable, so sometimes it's a heavily calcified distal lesion, I tend to use sirolimus. And if I'm using multiple drug in a same artery, because of the risk of embolization with these macroparticles with the paclitaxel, I tend to use more sirolimus. And finally, you saw the STEMI case I showed you. I often seen when you use a paclitaxel, the flow goes down. Then we have to give adenosine and usual other stuff to establish the flow. I tend to use sirolimus. So in my practice, around 70% of cases are still treated with paclitaxel, around 30% with sirolimus.
And
the
maybe
second question, sorry, Azim, you comment.
Maybe, Saul, is that what you say about paclitaxel-eluting stents is true. All the randomized, we don't use paclitaxel-eluting stents because they were associated with a higher risk of stent thrombosis and delayed endothelialization. When it comes to paclitaxel-eluting balloons, there's actually more data for it than sirolimus. And the head-to-head studies of sirolimus versus, or limus versus paclitaxel-coating balloons show they're very similar for clinical events, but paclitaxel is slightly better for late loss and for positive remodeling. So
Thank you.
the effect of I think the paclitaxel is good, but the fact that it doesn't stay there as long as it does with a stent is probably why we don't see some of the bad effects we saw with the stent. Sorry, Sandeep, carry on with the second question, which I thought was also very interesting.
No, I think that's a great point. You're right. The stent and the DCBs are totally different. You're right. And then the second question you asked, I think that's a very good question you asked, because if you look at the RIPS trial, you see there is the long-term data was better with a stent over a DCB in a first restenosis, as you said. But the way I look at it is, if I've corrected the mechanical issue, I can easily put a DCB, because if the DCB fails, I can always put a stent in. But if the stent fails, then you're left with a 2-layer of metal. So I would probably go more with a DCB as my first choice, because DCB failure is more forgiving than a stent failure.
Yeah, that makes sense. I guess for us, the cost will be a limitation because the DCB will be $5,000 versus a stent that's $400. But I see.
I think in your setup, I think you should go with a stent, unless you have like multiple layers of stents.
Or enroll in a clinical study, because we will have
you get paid for that.
Number of clinical studies here, Saul, for those patients. So we actually just got approved for the magical randomized control trial, which is a randomized study of a limus-coated balloon versus POLBA in patients with restenosis. Maybe we'll randomize in the clinical trial.
Outstanding. Thank you very much.
Andrea Gotti, and then we'll go to Andrea Mignati, and then to Chris, and we'll end with Antonella.
Hi, Sandeep. First of all, thanks for your talk. I have a question. I was interested in the patient you treated with dissection on the LAD, and of course, you have extensive experience on DCB, but in the US, we are about to start. So I wanted to know from you, what are your suggestions if you have, of course, a non-flow limiting dissection, which is your criterion or criteria not to stent the dissection? Do you use imaging, invasive wires, or just angiography? What would you recommend us?
So dissection is a problem with any POBA or even a DCB. Now, we've been told not to leave any dissection. This is the first teaching when we were started interventional cardiology, because default strategy is stents. But with the DCB, what happens is you are not have any metal work there. So if you have a dissection, you have to assess how is the dissection. If it is a type A or type B with no luminal compromise or a persistent dye hang-up, you can accept it. That's the current recommendation from the DCB consensus group. Anything more than type B, like type C dissection, that needs stenting. Now, even with type A and type B, the most important thing is not to keep injecting the contrast. If you see a dissection, I normally acquire till the contrast disappears. So the contrast is not holding up, and the lumen is not compromised with the dissection flap. I maybe do another injection, the last injection maybe 2 minutes later, to make sure that it's not getting worse. If it is not getting worse, I stop. Now, the times where we have had problems is almost like only one case where we had a dissection which closed off among thousands of cases we have done. So the risk of leaving a dissection is very, very small. And again, if you speak to many operators, they say it. Probably because we have a better technology these days, balloon technology, better imaging, so we can see the resolution so nicely, and probably the antiplatelets, because we all use these days prasugrel, ticagrelor, stronger antiplatelets as compared to what it was in POBA era. So I would say, yes, dissection is a problem. You have to evaluate it. In the initial phase of your DCB experience, you generally tend to do more bailout stenting. So if you look at any DCB practice, they don't want to leave dissection because people say, I want to sleep at night. Okay, so you tend to do more stenting. But over time, that drops because you see so many dissection, you leave and they heal up, and patient had no like an acute closure or whatever. And the last point is, when you have these kind of dissections, one of the worry we people say is that, are you going to come back in the night? Are you going to do that? Yes, those worries will be there. But if you give yourself more time with your experience, eventually you'll get better and you'll start living these dissections. Is that answer my question? Your question?
Yes. Yes. Thank you.
Mark, we'll go to Mark, Andrea Mignati, and then we'll come to you. Mark, you had your hand up?
Yeah, I just was curious, since we were successful for years using beta brachytherapy, but it kind of fell off the map after drug-eluting stents came out. Is there any point now to doing a head-to-head with drug-coated balloons versus beta for in-stent restenosis?
Well, maybe I'll take that. So, when I started working in Europe, there was still brachytherapy available for restenosis. And it was being used in a couple of centers, including in Milan, in Rotterdam. When drug-coated balloons came out, brachytherapy completely died. Every enthusiast of brachytherapy moved away from it and stopped using it. And I think the feeling was just the toxicity of it to an artery was just not worth it. Because, and I don't know how many, I'm sure you've seen a lot in your career, Mark, but all the ones I've seen, you have come back with like late restenosis, they've come back with aneurysms and so on. So I suspect the same thing will happen here in the US. When these drug-coated balloons are fully available, or they reimbursed, or the price comes down and we have easy access to them, no one will do brachytherapy anymore. It's just, if you look at the late loss you get with these balloons, it's just so good that there's very little reason for brachytherapy, and just the toxicity, the difficulty with doing it, and also, let's face it, doctors don't want to send their patients to other centers if they can have a solution to treat them, right?
Sure.
So whoever, all these guys who been doing brachytherapy that are referral centers, all those referrals will stop. Because if you now, a center that sent them these, and now you have a drug-coated balloon that you can just use, you're going to do that, right? And you're going to avoid multiple layers. And so I mark my words, maybe I'll be wrong, but I suspect in 2 years from now, there'll be no more brachytherapy in the US.
Thank you.
Andrea Mignati?
Yes, good morning. I actually had the same question as Andrea Scotti's was answered. It was in regard to the bailout strategies for dissection. So I'll change my question to your approach to acute coronary syndromes and STEMIs. And do you see a role? To me, intuitively, it's counterintuitive to me to balloon a high burden, high clot burden lesion with the risk of slow flow, no reflow. It kinds of goes against what the teachings or the practice is right now, but it seems to be working. So I just wanted to know, did you change your practice also for regular STEMIs? Like, do you use more aspiration thrombectomy? Do you prepare the lesion differently? And do you see a role? I know there are studies, but do you see a role of DCBs in STEMIs?
Yeah, that's a good point. Actually, you're right. I mean, there is no randomized trial. In fact, I'm trying to see if one of the companies can sponsor a trial like that. It's going to be a difficult trial to run, STEMI. But you're right. The way I do is I do simple. I aspirate if I want to aspirate if there is a lot of clot burden. If not, I'll just balloon it. I establish a TIMI3 flow, and I ensure there's no significant recoil. If that happens with even just a semi-compliant and NC balloon, I'll accept it. I don't need any fancy scoring balloon or thrombus aspiration. But the advantage of not stenting at the time is, you're right, you're not sizing the vessel properly, because vessels probably undersized generally in STEMI. And as you said, thrombus there gives you a slow flow. I just give them GP2B3 inhibitors for 12 hours, sometimes even 24 hours. And I just use a DCB and I just leave it. And many times I come back, I don't even see a lesion. Okay. Even if there is a lesion, let's say I put a short stent rather than putting a long layer of stent, what I probably would have done in the setting of a STEMI. I probably minimized the length of the stent I used. So I used a case of the day. I came back. There was a focal recoil in where the actual occlusion was. I put a 4 by 15 millimeter stent, and it was it. So as you can use it. And one thing about the dissection I forgot to mention earlier, I think is right. The same thing with the dissection. If there is a dissection or a focal recoil, rather than putting a stent from end to end where you use a DCB, you could only use a focal stenting. So which means you could still reap the benefit of the DCB, but address the focal issue of a stent or with a recoil or a dissection.
I actually, I think, Andrea, I think there'll be a lot of interest for STEMI. I think there is already a study. I think there was a PEPCAD STEMI study already.
Yeah.
If you want to go look at it. But, even with drug bioresorbable scaffolds, there was a lot of interest because these are often younger patients. They have softer plaques. So, if you think about women also, younger women presenting with STEMI where, they have endothelial erosion and not a lot of plaque, those would be ideal candidates. So, no, maybe not as every patient, but I can definitely see a role where I would use drug.
Yes, you're right.
I think, what you described in the case you show, where you aspirate and there's minimal disease afterwards, but for me, that would be a good one. Or where there's this big change in vessel diameter, like the PDA case you've shown. I also like those kind of cases for drug-coated balloons and STEMI. So I think there will be. I don't think we're going to replace stents there because I think you're right. There are times where a stent helps you trap some thrombus, but I can see where we're going to be doing more and more in the future.
Thank you.
Okay. We're going to move on to Chris. Juan, I see your hand up. I'm going to move to you afterwards. Chris, did you have a question before we go to Antonella?
Great talk, Chris. Quick question. Is there ever a reason to repeat the DCB? For example, if you have a patient that has 2 layers of stent already and they have ISR, how often do you ever bring a patient back to do another DCB?
No, so if the DCB fails, the option is either to go back with another DCB, like if paclitaxel fails, I could use a sirolimus. If a sirolimus has failed, I could use a paclitaxel. But I have had cases where I had to use a stent in. But before that, as I showed you in those 2 cases, you have to ensure the mechanical issue is addressed. Despite of all this, patient's factor will play. Diabetic, renal failure, they acquired more disease, you have more neointimal hyperplasia. So if I do an OCT and I see a lot of neointimal hyperplasia or neoatherosclerosis, I tend to use more stent if there's only 1 layer of stent. Whereas if it's more of a hyperplastic tissue, DCB is perfect because you want that to regress. Neoatherosclerosis, there's a doubt whether we can live with a DCB. I've left it many times, but for that you have to do OCT to understand. But if the mechanical issue is corrected, I always use DCB as a first choice because even if it fails, I can put a stent in. It's more forgiving than a stent failure.
Or you could put another DCB if you needed to. Yeah, there's no limit to how many you can use other than costs, I think. Antonella?
Yeah. Hi.
Hi.
I just have a question because I went through a meta-analysis recently that showed that use of DCB is as effective of death for bare metal stent in stent restenosis, but it's less effective than death for death intra-stent restenosis. Maybe I read that meta-analysis with non-expertise. So I was wondering how did you interpret those data?
I agree with you. I've seen the paper. Sorry, you had more question?
No, and then just yeah, you show us there are like so I've a lot of evidence about using DCB for small vessel. Why do you think they are like indication of DCB for small vessels are not yet included in guidelines? Do you think that they are gonna change in the future?
Yes, I think that's a good question. I'll answer your second question first because I'm expecting, I'll be very surprised that if they don't put de novo lesions, at least small vessels in the next ESC guidelines, because there's 5 RCTs now, and 3 of them are recent ones. So when you have 3 RCTs, like basket small to picolet and this China one as well, restore, you're compelled to put that in. So they may give a class, I don't know, 2A or something, or 2B, whatever, but I think it will be there, it will come. But we have guidelines. We got some evidence to use DCB in small vessels. Your first question is very interesting because you're right. I've spoken to Bruno Scheller and the RIPS4 investigator. They have done trials. So if you look at the RIPS4 long-term data, it favors more drug-eluting stent than DCB. Probably because these are all first ISR where operator have corrected a mechanical issue and maybe there's recall, you use DCB, they come back with more events. But with a stent, you get a better MLA or MSA. So maybe you'll get a better flow into the artery and maybe that will remain open for long. Maybe the bare metal restenosis will be less and less see in the time because probably those patients who receive bare metal stents will eventually die and we may not see many. In fact, in the last few years, I've seen maybe 2 or 3 cases of bare metal stent ISR. So our challenges will be drug-eluting stent ISR. Going by your meta-analysis, yes, you're right. If you have a drug-eluting stent restenosis, if the mechanical issue is corrected, you could use stents as well. So which is why ESC guidelines give class 1 indication for even for stents. So you could use either, but the way I look at it is I want to avoid another layer of metal, especially if the patient have failed with the previous stent. And even if they do come back, I'm happy to put a stent in. So that's why I do it. In fact, I'm sure Azim would have done the same thing when he was in Italy. But equally, if you have to use a stent, you have that meta-analysis, you have RIPS4 trial, a long-term outcome which supports stenting better than DCB.
Okay, thank you.
Well, Juan, you had a question, last question, then we'll let Sandeep go.
Yes, thank you so much for your presentation. So we know that these drug-coated balloons are especially indicated for like these small vessels and also like the in-stent restenosis. But I was thinking with this possibility to add drugs to the balloons and not only on the stents, is there any potential role on, I'm not aware of the literature, but antithrombotic medications on the balloon just to avoid like thrombosis in the early thrombosis in very severe bifurcation or complex lesions? That's my question, I guess.
I think you mean like a coating locally on the drug, on the balloon you meant?
Yeah, correct. Yes. Like antithrombotic drugs just to avoid thrombosis, yes. Instead of
so there are 2 balloons coming out. One balloon's coming out where they've got both paclitaxel and sirolimus in the same balloon. And there's one balloon's coming out where they are putting a small dose of these anticoagulants. But I don't know, these are still early days. The good thing is that DCB is now evolving big time globally. So I'm sure these ideas will crop in, people will do trial, and maybe it might be better to have maybe a bit of paclitaxel, a bit of sirolimus, a bit of, I don't know, these DOACs or maybe all these new monoclonal antibodies onto the drug, a balloon. But we don't know yet. I think it's too early days, but it's a nice idea. What do you think, Azim?
Yeah, so it's a great question, Juan. The one thing I say, drug-coated balloons, the risk of lesion thrombosis or vessel thrombosis is actually pretty low. So I don't know how many you've seen in your career, but if you look at all the randomized studies, it's actually much lower with a drug-coated balloon compared to a stent. So again, when you develop these things, you have to think about clinical need, right? I mean, what is the clinical need? What are we trying to prevent? If there's a very low risk of thrombosis and it's less than 1%, imagine how big a clinical study you'll have to do. It'll be like an 8,000 to 10,000 patient clinical study. And so no one's unfortunately going to do that. It's going to cost too much money. But we did try this with stents, and Mark will remember there was a time when there were heparin-coated stents many years ago, bare metal stents that were coated with heparin or were coated with other antithrombotic agents. There were even stents coated with monoclonal antibodies that facilitated, I think it was anti-CD, what is it?
Yeah, it's the CD4 thing. It was called Gina stent.
CD4, that's it, yeah. And that promoted endothelialization, all right? None of those stents actually showed any benefit as regards to thrombosis. So I think the appetite for doing that certainly has decreased. But I do think we may see some combinations. So, Sandeep mentioned this balloon we've been working on now for like 3 or 4 years, called it's called Surplus Duo, where we've put sirolimus and paclitaxel on the same balloon in different dosages. So like 90% limus, 10% paclitaxel. And the idea is maybe we can get the benefit of both drugs, because one is cytotoxic, the other one is cytostatic, right? And so they work down different mechanisms of action down the cell cycle. So we've actually done now 30 patients in a OUS study in Australia, New Zealand, South America, and the data looks very promising. And so hopefully now in discussions with the FDA to start a de novo study. So I think we'll see more drug combinations, but it becomes also very expensive and difficult to test these and show benefit over current therapies.
Yeah, I agree. I think that's a good point. I think what you made is the right point. Acute closure post DCB, and the entire 10 years of we have seen maybe 2 to me, one of my friends. So if you look at the amount of, or the frequency or the incidence is so low, it's difficult to show any benefits with these new drug and everything.
Thank you.
Sandeep, that was great. And also it stimulated fantastic discussions. So I want to also thank all the fellows and attendings who joined and made the discussion so interesting, but especially you, Sandeep, for giving us an hour of your day.
Pleasure.
Fantastic. You owe me another talk on CTOs, because I want that talk too, but we're going to do that later in the year in September, okay?
So I've already put I think it's end of September. I've already put it in.
Fantastic.
So I got the invite back. So just, I'll show more of CTO cases then. But
Awesome.
thank you so much. I mean, as I said, Azim and me go back almost 11, 12 years now. So I've got a lot of respect and regards for him. So you are all lucky to have him. So yes, thank you, Azim, and thank you for everyone giving me this opportunity to give you a talk.
Take care, my friend. See you soon.